Salam, hörmətli qonaqlar, dəyərli kollegalar, dəyərli müəllimlərim, burada iştirak edən müəllimlərim, çox dəyərli vaxtınızı ayırıb gəldiyiniz üçün çox sizə təşəkkür edirəm. Xüsusi olaraq moderatorlara minnətdarlığımı bildirirəm və qonağımı sizə təqdim eləmək istəyirəm. Qonağımızı bu arada bugün bir tur elədik onunla, çox həddən artıq razı qaldı və Bakını çox sevdi. Deməli, qonağımız Profesor Tarek Shaarawy, hal-hazırda Beynəlxalq Glaucoma Cərrahiyyə Cəmiyyətinin prezidenti və Ümumdünya Glaucoma Assosiasiyasının vitse-prezidentidir. Biz onun kitabları əsasında glaukomanı öyrənmişik. Hal-hazırda glaukoma üzrə 5 dərsliyin, 100-dən çox kitab fəslinin və bir çox oftalmologiya jurnalının, o cümlədən Beynəlxalq Ophthalmologiya jurnalı, Glaukoma jurnalı, Kanada Ophthalmologiya jurnalı və Yaxın Şərq Afrika Ophthalmologiya jurnalı, Asiya Sakit Okean Ophthalmologiya jurnalı və bir çox başqa jurnalların redaksiya heyətində xidmət edir. Resenziyalı jurnallarda nəşrlərin müəllifi və redaktorudur. Profesor Tarek Shaarawy eyni zamanda İsveçrənin Swiss Vision göz mərkəzinin CEO-su və təsisçi tərəfdaşıdır. Bildirmək istəyirəm ki, Swiss Vision dünyanın bir çox ölkələrində klinika olaraq fəaliyyət göstərir və bu yaxınlarda artıq Misirdə fəaliyyətinə başlayır. Profesor Tarek Shaarawy həmçinin Geneva Universitet xəstəxanalarının glaukoma bölməsinin və glaukoma cərrahiyyəsi tədqiqat qrupunun rəhbəridir. O, Geneva Universitetinin dosenti, hal-hazırda dediyim kimi Beynəlxalq Glaukoma Cərrahiyyə Cəmiyyətinin prezidentidir. Xoş gəlmişsiniz. Ümid edirəm ki, bu dəyərli görüşdən evə çoxlu mesajlarınız olacaq. Dəyərli cərrahlar və həkimlər, çox sağ olun. Bir də gəldiyinizə görə böyük təşəkkürümü, minnətdarlığımı bildirirəm.
Thank you very much for the introduction. I recognized my name. It's an absolute pleasure to be here with you. And this is my first time to your beautiful country. It has been so far an exhilarating experience, actually, roaming the streets of the old city and looking at the unique culture of this beautiful country, as well as its modern aspect that has been really absolutely inspiring. So far, I've been here for a bit more than 26 hours and I loved every second of it. I cannot exaggerate actually the very strong impression that I have had. Thank you, Zebda, very much for your generosity and for your kindness having me here. I actually am surprised with the big number of ophthalmologists wanting to listen to a glaucoma lecture, but I'll do my very best to speak about the little that I know about this difficult type of a disease. So every now and then, if you get somebody speaking about what is new in glaucoma or what is new in ophthalmology, and every few years we're talking about huge leaps in what we're doing and how everything has changed. So I hope that you do not take this talk as just any other talk that speaks about how different life is going to be or how big the changes that we are facing now. So there is a word in English that I like very much. It's called disruptive technology. So disruptive technologies are technologies that take a pace or a way of how we're doing things and change it significantly into another aspect. And I think truly this time we are on the cusp of major changes in our practice as ophthalmologists and specifically in glaucoma. So to help me explain my point, let me introduce this patient. This is a patient that came to my practice in Geneva. She's a Kuwaiti princess, 53 years old, has an early open-angle glaucoma on 3 molecules, suffering from dry eyes, and her intraocular pressures are in the range of 21 millimeters of mercury. With a certain damage of the optic disc and visual field, so this is not a scenario that any ophthalmologist will not meet. And the question is always what to do and how aggressive you should be. Now, given glaucoma is a slowly progressing disease, so you should not be terribly aggressive about every single patient. Not every single patient we have to take from his or her hand and take them to the operating room to cut through the eye. So there has to be ways to guide us. At one point, should we take an aggressive pathway to try to reduce the pressure significantly or not? So like in any other disease, glaucoma has to be managed and stopped. And I love this video because this is a video of one single patient in Geneva, over 20 years of optic disc photography. What does that tell you? It tells you that glaucoma progresses, yes, for sure. But it also tells you that even in a sort of center of excellence, where we follow the patient and have no major issues, let's say with money or expenses, we still can have a patient that will progress under your hands. So not all factors are controllable by the doctor. There are things that are, basically we do our best and it doesn't always work. But we have to manage those diseases based on what we have in our hands, the treatments that we have. And you know, medications, SLTs, procedures, surgical procedures, filtering procedures like trabeculectomy or deep sclerectomy, mix with all its different types, or putting tubes. We have many options, and everything has to be based on what we call the current evidence-based management that we have, which starts with, funny enough, expert opinion. So expert opinion really doesn't count for much. What really counts is pooling our own knowledge that has been published in peer-reviewed journals, in multiple randomized controlled trials, to try to make sense of the overall knowledge that we possess as doctors. But every single doctor thinking that he knows everything doesn't work. We do not know everything. We know very little. Together, as a community of ophthalmologists, maybe we know something or another. So, when we want to manage a glaucoma case, we have to consider risk factors. When should you be aggressively trying to reduce intraocular pressure? First of all, any patient that comes for you with this kind of a disc, this is an advanced case. This is not a case where you have the luxury to wait a couple of years to see if the patient will progress or not. You have to be aggressively wanting to reduce the pressure. And I don't know how many of your cases come in that situation, but Switzerland as well. I get about 10% of my cases coming already in an advanced stage. So it is a situation where you have to manage those cases. Now, also for the young ophthalmologists, you can have an optic disc that looks damaged but not too damaged. But you then do a visual field, and then you find that there are scotomas very nearby the fixation, very nearby central vision. This is again a case where you have to take very seriously, a case where you want to effectively reduce intraocular pressure, because it only takes a little bit of a pressure rise that the fixation will be cut, and then vision will drop from 100% to 10 or 20%. I had a case like that. In 1 week, I scheduled the patient, pressure was about 18. I scheduled the patient for operation. I saw him on Monday, scheduled it for Friday, and on Friday, the vision went down from 100% before surgery to 20% because the damage was selectively close to fixation. Very unhappy situation. So whenever you have a case where the fixation is what we call in English menaced, so under threat, this is where you should not take it lightly. By the way, in many countries around the world, people think that visual field is something of the old days. Patients don't like it, let's do OCTs. OCTs are beautiful, but OCTs will give you a piece of the puzzle. It's never the whole thing. So you still have to rely on looking at the disc, on taking photos of the disc, on doing OCTs and visual fields. We need to do all that, as well as gonioscopies, as well as pachymetries. Glaucoma is a puzzle, and every time you're taking pieces together to make what we call a guesstimate, a scientific guess based on an estimation that is built on your knowledge and experience. All congenital glaucoma cases should be managed aggressively, because putting a child of 2 months on on medical therapy for the rest of his life is not really practical. So here we are doing deep sterectomy with ab external trabeculotomy, which is my preferred technique as a primary procedure for congenital glaucomas. Any young person in his 20s, you always think of life expectancy. This is a person that will live with his glaucoma for many decades. Again, you are not going to treat this as a person that is 95 years old, where the life expectancy is shorter, given that now in Europe we have a lot of patients that are 95 and coming to our clinic riding their own bikes. So yes, numbers can tell you something, but does not tell you the whole thing. We know from our published studies that blindness from glaucoma runs in families. So any family that has a member that went blind because of glaucoma is in need of us taking it very seriously. Why? For 2 reasons. Because yes, people in a family where blindness happened from glaucoma have a higher potential of becoming blind of glaucoma themselves. But also, don't forget, you get somebody that is 40 and he knows that his father or mother got blind because of glaucoma, there is this huge psychological impact of a family history of blindness on those people. So it is very important to manage the stress, the lack of confidence, the lack of trust in the future in those people by bringing them more frequently to our clinic, by treating them effectively to give them the sense of security that they need. Nobody can live comfortably knowing that in his mind he's doomed to become blind. I don't know how high is pseudoexfoliation in your beautiful country, but in it's about 40%. It's very weird, this pseudoexfoliation thing. We find it a lot in Nordic countries, so Finland, Norway, Iceland, Denmark. And then you find it in Ethiopia and Saudi Arabia. So the distribution is complicated, and there are always theories to why there are this very, very weird distribution. But we agree on one thing. Blindness from pseudoexfoliation is significantly higher than blindness from primary open-angle glaucoma, so you should treat it more aggressively. Not only that, by the way, mortality among people who had pseudoexfoliation from cardiothoracic complications are higher than regular people. So for people with primary open-angle glaucoma, so patients with pseudoexfoliation should be also referred to their internal physician to find out if there's a cardiac issue related to that or not. And finally, patients with single eye. This is a young guy at that time when I started seeing him 20 years ago. He was an immigrant to Switzerland from Zambia, and he came absolutely penniless, had nothing, and he came to me 20 years ago with one eye lost, and we have been fighting ever since to take care of the only good seeing eye. And throughout 20 years, I had to deal with his anxieties, which are absolutely understandable. And one of the saddest moments of my life was that when he finally got a law degree and started working as a lawyer, and has enough and collected enough money to buy a car, and it was my responsibility to tell him, your visual field is terrible, you will never be able to get a driving license in Switzerland because of that. So again, this is a kind of work where you have to be multiple things to your patient, and usually in my clinic I keep time for the medical stuff for my patients, but I also keep a little bit of time where I speak about their families, I speak about their lives, I speak about politics, I speak about whatever because you really always need to be close to your patient. A glaucoma patient is there in your neck for your natural lifespan, or his or hers. One expires before the other, but usually if you're doing a good job, they're with you forever. But again, unfortunately, I'm talking about risk factors and us having to be, very, very clever, in some cases being aggressive, but it is not straightforward. If you look at the ocular hypertension treatment study, for example, you find that 12% of untreated converted to primary open-angle glaucoma, which is only 12%. I mean, the rest did not convert to glaucoma. And then you see the Latana Cross study in the UK, which again gives you a very interesting number, that 75% when we treated the patients did not progress. So what I'm trying to tell you is we are not clever enough with our set of current risk factors to know for a fact who is going to progress or not, and who we should treat aggressively or not. So far, I've been giving you guidelines, but then I'm giving you studies that say that the guidelines, although they're sweet and nice and meaningful, they do not always work. So, how do we manage that? Now look at this graph, which is, to my mind, one of the most important graphs that I used in my whole life. And we have been following those patients for more than 40 years. And if you can see, those patients have progression in the left eye or the right eye over a period of 40 years. Now, what does that tell you? It tells you basically that there is a group in this square, in the red square, that have been always destined for progression. And this is where we have to put our effort and money. This is where we have to take our practice very seriously. We have to treat those people very seriously, because those are the people that are going to progress. How do we know those people, and how can we identify those people? Well, now this is what is changing in ophthalmology, is the combination or the combined effort of man and the machine. A lot of people are extremely, worried about the introduction of artificial intelligence in our domain, in our work. And a year ago, 25 CEOs from California, from the Silicon Valley, issued a warning to humanity, saying that the advances of artificial intelligence is going to be an existential threat to the human race. Existential threat. And they said this existential threat is as bad as an epidemic or as nuclear war. So really, really, really, big words. But I'm a pragmatist when it comes to my work, and I feel that we are never going to, at this phase, stop the progression of artificial intelligence. So let's at least use the good aspect of it, and hope that before we are all ruled by machines, that we can at least make use of them for the better good of humanity. So we have a program on artificial intelligence that we have been working on for something like 6 years now. And the idea is to use artificial intelligence not only to screen for glaucoma, which is a big, big issue. Please understand that not a single country on this planet has an effective screening program. Doesn't exist. Not Europe, not North America, never. Not Hong Kong, not China. There's no screening program. But what we want to do is to find a screening program that can detect and predict which patients will progress or not. And it works very well for ophthalmology. Why? Because we are a subspecialty that is focused on imaging. We use imaging all the time. We have a lot of data. If you think of all the data that you have, every single examination of your patient, there are lots. And we have very few specialists all around the world, by the way. The number of specialists needed for this planet is ophthalmologists are much less than what is really needed, what we really have. We have very few ophthalmologists in any place around the world. And as I said, screening programs are underdeveloped. So, thinking of artificial intelligence as the great equalizer between those who have and those who have not, we started a very ambitious screening program in our foundation that we created in 2003 in the south of Egypt. It's called Baladi. The word Baladi means my country. And although I think that artificial intelligence can pertain to any community, but we really wanted it in a place where you have one ophthalmologist for every 200,000 people. And this was not the scenario in Switzerland, for example. It was a research program that unfortunately was done in very dire circumstances. The graph that you see is the value of the Egyptian pound versus US dollars over the last 20 years. I don't know how your currency is doing, but our currency has not been doing that well. So putting an economically interesting research program in a tough environment, and it was not that easy to tell you the truth. We started with this camera that we did with the Indian company, where we created a camera that has a smartphone-based application, and we validated that against very expensive machines. You put, an Android or an Apple computer in the back, and very simply we can teach our optometrists and technicians to take the photos. And what is really nice is that it works through an app on your phone. And this app can work also offline. So you don't even have to be connected to the internet to work on that. And then we actually looked at it on two diseases. Sight-threatening diabetic retinopathy, a huge challenge for ophthalmologists worldwide, and glaucoma. And the device can really help you to identify with a very high incidence of sensitivity and specificity. You can see here, it's quite high to identify diabetic retinopathy, and to my mind, this is really an unmet need. And for glaucoma, the challenge was very difficult, because you can see here in front of you 3 optic nerves. And the funny thing is that the 3 optic nerves are normal. The CD ratio looks very different, but the CD ratio, always remember, it's always related to the size of the optic disc. So again, to the young ophthalmologist, it means nothing to measure the CD ratio without first measuring the horizontal and vertical diameter of the disc, and second, actually putting in your notes what kind of lens you were using. Because if you're using a 90D, the results are very different than using a 66D, for example, diopters. So please remember that you can have a 0.9 cupping in a physiological cupped optic disc. So the challenge was doing an artificial intelligence program that will understand those different kinds of discs. So again, we ran the study with the Indian-made company and Indian-made camera, and the agreement between a panel of expert ophthalmologists and the artificial intelligence was really good. But then we thought, well, we needed to go further a little bit, so we started a program with our Ministry of Information Technology, where we actually created this setup. Those are the Aura commercially available cameras, that we started doing our own artificial intelligence engine. And the funny thing, and not funny, actually, the difficult thing is, once you are doing your own artificial intelligence engine, you unfortunately have to screen your own population. Because you cannot get optic nerve heads from India or America or Switzerland or Egypt and run them against your own people. You really have to do your own homework. So the setup, as you can see, 1 laptop, 1 camera, and 1 eye care tonometer. And again, the technology is very easy to use, but we had to do about 80,000 eyes. We had to take photos of 80,000 eyes. And then through the 80,000 eyes, we started actually screening through 3 levels of experts to teach the machine. Of course, this is the work of engineers. We were just looking at photos, but you had to have a backing, clever engineers behind you to look at the engine, and we are telling them this patient is this or that, but at the end of the day, there is a very specific effort for this engine to be able to identify if this patient is glaucomatous or not, but it's always based on how the artificial intelligence is as good as intelligent as you will teach it to be. So that's why we had to go into 80,000 eyes to be able to have something that is useful. And again, for us, the whole idea was to have to equalize the care that we give to our patients versus the care that is given in North America or in Switzerland. You know how poverty can affect patients. And by the way, glaucoma is the story of those 2 ladies. Okay? Very simple. One lady here from Afghanistan, you know the Afghan Mona Lisa, of course. And the difference between each of this photo is about 8 years. It's an incredible aging process. Civil war. Wars are bad, and civil war would take this beautiful young lady and after 16 years makes her this old lady that has very little hope in life, and this is really glaucoma. Glaucoma will take a healthy, beautiful optic nerve and will make it really aged and dysfunctional with time. So this is a lady living near to Kabul, and this is another lady that lives in Los Angeles before the fires. And you can see 1979 to 2009, same dress. Of course there are changes, but they're subtle. They're not too big, and that is a slowly progressing glaucoma. Our job as ophthalmologists is to try to catch those small changes to know if the patient is stable or not. So that also brings us to a huge important tool that is now available. It's not going to be available, it's available, which is basically looking at the genetics of patients to try to figure out if they are progressing or not. So look at this study. Finding one single gene in this study, the TMCO gene, would actually account for 3 times the increase of risk of developing glaucoma, would also account for extra 33 years of age, 3 decades more, or an extra 0.43 CD ratio, or an extra 12 millimeters of mercury. So somebody that has an 18 millimeters of mercury and has this kind of gene, we know that you should treat him as having 30, not 18. And this is absolutely scientifically valid. So in Switzerland, now jump into the other side, I wear my Swiss rich, expensive hat. We started a program where we are doing genetic profiling for every single adult person in Switzerland. It costs us $20 per person. I thought it would be more actually, but $20 for Switzerland, it's basically 3 cups of coffee. Not too bad, not too bad. For how many cups of coffee would be $20 in Baku? How much is a cup of coffee in Baku? A good cappuccino? $5?
6 cups. $3.
$3. So, I mean, here it's 3, there it will be about 6 point something. Not too bad, it's doable. So, I'll show you when we did that, then we started having a profiling for glaucoma for those patients. And I can show you mine. My own glaucoma likelihood genetically is exactly 15%. I have a 15% risk, which falls into the typical likelihood. It's not 0, it's 15%. But we can find patients who are 80% or 90%, and that is a genetics test that does not just cover glaucoma, it covers all types of diseases. So you can imagine the enormous impact of having genetic profiling for your patients. There are, of course, issues that has to do with confidentiality. with how you store this information, all this amount of big data that we have to work with actually comes with lots of challenges. So this is something we have to think about. Now, every single one of you as ophthalmologists would have had a patient coming to you and say, you know, even for retina, I have a diabetic retinopathy. Should I drink coffee, tea? Should I exercise? And usually our answers, to be honest, are really, you know, empirical. You always have to exercise. Exercise is good for you. You have to sleep well. You have to rest. You have to, you know, don't be angry. Don't be stressed. Easier said than done. But then when there are specific questions, should I drink coffee? It's really difficult for you to answer. But if you look at science and genetics, for example, coffee. And Louis Pasquale published a very nice study that shows coffee reduces pressure, which is good, except in a subgroup of patients that are genetically predetermined that if they drink coffee, pressure will go high. So now it's really good times for us to be able to give true scientific answers that affects the living standards and living conditions of patients, and give real specific answers to patients about something as banal, as normal as drinking coffee. So back to this lady, the Kuwaiti princess. So 53 years old, early primary open-angle glaucoma, 3 millimeters of mercury, dry eyes, IOPs around 21. Who would increase the molecules? Who would go from 3 to 4 molecules? No one? No, absolutely no one? Who would take this lady to the operating theater to do a trabeculectomy? I'm sorry?
We should check the pachymetry.
Pachymetry is normal, 530. It's within normal. So, surgery? No surgery? Okay, oral anti-glaucoma therapy? No?
Do we have the visual fields OCTs?
It's affected.
Affected.
It's not extremely advanced, but it's advanced. You have a nasal step and you have an OCT that shows damage compared to the normative database.
Definitely surgery.
Definitely surgery. Who else is there for surgery?
It depends on 3 molecules. Which of them? Combine molecules or some?
The 3 molecules are prostaglandin, beta blockers, and carbonic anhydrase inhibitors. Those are the 3 that are being used.
Okay. What about the alpha agonist?
She was not taking alpha agonist. Would you like to add an alpha agonist?
Why not?
Okay. I wouldn't, because she has a dry eye. So putting an alpha agonist on that, probably she will not be very happy, but I give you, why not? Why not? There's no perfect answer. Who would go for an SLT?
Does she have the money to pay for the surgery?
She has the money, so she's a Kuwaiti princess, come on. I mean, she can buy all of us. So, who would go for an SLT?
But this is advanced stage, though.
Sorry?
This is advanced stage, the glaucoma?
It's not very advanced, it's early.
Early.
Yeah.
So SLT is one of those.
Okay, SLT is one of the options. But the majority of you did not raise their hands on one of the options. So basically you would do nothing. I disagree, we should do something, all right? So for that case, actually, and my answer is not as good as anybody, or as good as anybody, I decided on an SLT. Very simple, takes a few minutes, will supposedly live happily ever after. By the way, the NICE guidelines from the UK now advocates SLT as primary therapy for glaucoma before drops. So in the UK, they tell you, once you diagnose, take to SLT and don't start with drops. But again, that's only in the UK. Why? Because SLT basically shows that patients can be 74% drop-free for 3 years. Not too bad. Imagine the amount of saving that you will do to your health system. Enormous amount of saving. And for the ocular surface of the patient, instead of bombarding them with drops, they will be basically free for 3 years at least. Not too bad, not too bad. But Again, in ophthalmology as in medicine, I always tell my patients, ophthalmology or medicine is not engineering. We do not, build a building with specific dimensions. Everything is very, very in a gray zone. So this lady, by the way, genetics also in one study that we have just finalized can show if the patient will respond well to SLT or not. But this, back to the Kuwaiti lady. She calls 2 days later and she says she cannot see well. So I say, we increase a little bit the corticosteroids, prednisolone eye drops. I'll see you in 2 days. She calls 2 days later and she says, I'm not happy, I'm not seeing well. So we bring her back, and for the first and last time in my career, I find that she developed decimate folds immediately after the SLT, and the vision dropped from 100% to 20%. Nobody's happy. Just before my summer vacation, I canceled my summer vacation, I stayed with her for a whole month, taking a look at her eyes every 2 days, and putting her on a lot of steroids. The pressure goes up. We could have to put her on oral carbonic anhydrase inhibitors, Sidamex, or I don't know if you use Sidamex or Diamox, whatever. And I have 4 weeks of unhappiness by the patients, and 4 weeks that I was supposed to be on the seashore in my newly bought house at that time on the Mediterranean that I couldn't go, family away, and at the end she recovers. But this is medicine. You can do your best, and things do not always go in the right way. So I'll stop here. I was asked to do a break in my talk. The next half is talking about glaucoma surgery. I don't know if do you want to take some questions now? Or do you want to go for coffee? Your call.
1 second, please, Professor. Kimin sualı varsa bir hissemiz bitti. Kimin sualı varsa profesora verək, sonra fasiləyə gedəcəyik. Birinci hissəni bitirdi, ikinci hissəyə geçəcəyik.
I have a question.
Yes, please.
So, you had a very nice video when you showed the progression of the visual field with more than 40 years. But I noticed, interestingly, the majority of the patients progressed in the first 20 years. Then it slowed down. What's the reason for that?
People died. We had less patients going all the way to 40 years. That's really the reason. But also you can see from the graph that there's a big group that is. So we do not have to be aggressive with every single patient. The challenge is finding out which patients are distant to progression. At 40 years, a lot of patients actually dropped off. Following a group of hundreds of patients for 40 years was a huge challenge. And I have to hand it to the Swiss system, because I see patients that have been seen by Goldman. I have some of my patients that have been operated by Amsler, just imagine that you see a patient that was operated by Hans Goldman in the 50s, and you see them now when they are 80 years old and have congenital glaucoma. And you can see the filing system is so perfect that in my patients, those patients that have been treated by Amsler or Goldman or Vogt in Zurich, you still have the records scanned with their own handwriting. You look at that and you feel how small you are in the big scheme of things. Questions?
Yes.
The next part is going to be about surgery, or
Yes.
So can we finish with Can I finish with therapy?
I have one question. Actually, you have very bad story with Queen lady, Princess.
Yeah.
Actually,
It's a bad story, but it is exceptional. It is just to say that you can always do your best, but there are no guarantees, and this is also what we always have to tell our patients. We're doing our best.
yeah. Question is about the SLT. You use 90 degrees laser?
360.
360.
360 for every single patient.
Oh.
I do 360, and if I can do bilateral, so on the same setting, both eyes, it's better. Because you do 360, the patient has a bit of discomfort for a day, and then it's done. Instead of doing it, the patient is not happy in one eye, comes back in 2 weeks and does the other eye. So, and we did a study comparing 180 to 360, and 360 is significantly better in terms of pressure reduction.
So if the patient had the 21 pressure, so you try to do the 360, not 180?
I do 360 in every single patient, and I am, over the years, I've been using more and more SLT. Any patient that has problems with compliance, go for SLT. Any patients with dry eyes, go for SLT. Any patients where the pressure obviously is not in the good margin, SLT can at least help you reduce the number of drops that are being taken. So patient on four drops per day, this patient is very unhappy, he or she has dry eyes, they are very uncomfortable. Why not do an SLT? Even if you reduce the drops from 4 to 1, that's a big benefit.
I have a question regarding congenital glaucoma patients who was operated in 50s, how they were doing, and do they had any issues with glaucoma later at their 70s or 80s?
The patients that were treated with glaucoma in the 50s mostly had ab externo trabeculotomies. There was some that had goniotomies, but if I remember correctly, Barkan introduced goniotomy in the States around the 40s, and it was not very popular because in the 40s you did not have fantastic gonioscopy lenses, and you did not have the right tools to do goniotomy easily. It's only Goldman, again in the 50s, when he introduced the 3-mirror. You know, everything that, again, for young ophthalmologists, half of the things that you're using now have been done by Goldman. I mean, the perimeter, the slit lamp, the modern slit lamp is Goldman. The lenses are Goldman. Goldman is, and by the way, speaking of Goldman, Goldman was never admitted as a member of the Swiss Ophthalmological Society. He was a professor in Bern, the capital, and because of anti-Semite or anti-Semitic tendencies in Switzerland at that time, they actually did not allow him in to the Swiss Society, except 1 year before he passed away. Professor Fankhauser, who in the 60s and 70s was the professor of ophthalmology in Geneva, offered him an honorary membership of the society. But can you imagine how politics can also play, politics, racism, whatever, how that can look at the biggest giant in ophthalmology in the 20th century and say he's not good enough to be a Swiss ophthalmologist. So yeah, mostly external trabeculotomies. Most of those patients, actually when they came back, some of them worked perfectly well, and some of them we subjected to sort of periodic cyclodestruction. So every year we do a session of cyclodestruction. Pressure is quite well, and these eyes are very, those eyes, in my experience, were very resilient for optic nerves. They did well. I don't think I ever put a tube in an eye that Goldman did. Let's say it that way. Maybe also out of respect.
Thank you.
One question. What do you think about 24-hour IOP measurements? Do you think we should use it in cases where it's difficult to predict the...
If you look in the literature, you will find that the first study ever on 24-hour with a contact lens was published by my group in Geneva, where we were using the SensiMed contact lens. Still, we have it. SensiMed can measure the pressure 6 times per second over 24 hours, and the patient wears something like a Walkman. I'm sorry, the young people will not understand what a Walkman is, but a device that records the pressure 6 times per second, and we did a lot of studies on that. We were the first to say that beta blockers do not work at night. We found that the combination of alpha agonists and beta blockers both do not work at night. I think it makes sense in many cases, but I do not think that the technology for putting the contact lens over 24 hours is something that you can do for every single patient. You can do for very specific cases that are progressing despite that the pressure when they come to you are fine. But overall, I think that the 24-hour intraocular pressure, the real value is actually immediately after you diagnose glaucoma. For me, this is the golden window. You diagnose glaucoma, and you have two ways to do it. You diagnose and treat, or you diagnose and wait and understand. And I would tell you that you should diagnose, wait and understand 10 times out of 10. Because you need to know, for example, how high is the pressure. So a patient comes to you and the pressure is 24 with a damaged optic nerve and positive visual fields. If you treat and you go from 23 to 19, this is not a big decrease. But if you do a 24-hour pressure and you find that he or she goes up to 30 and you treat it from 30 and you went to 19, this makes a huge difference. So that the minute you diagnose a glaucoma, your job is not to treat. Your job is to document, understand what you're dealing with. Because glaucomas are not born equal. And you need to know what you are staring in the face. Is it the beast that will eat you alive? Or is it like a tame, beautiful cat, as the beautiful cats that I saw in the streets of Baku today? The glaucomas are different. So they can all be felines, but there are cats and then there are tigers.
Thank you.
Any question? Hər hansı başqa bir sualı olan varsa verə bilər. Yoxsa fasilədən sonra ikinci hissəyə keçəcəyik. Sual?
First of all, I want to thank you. I appreciate your coming to Azerbaijan. I have one more question about the corneal hysteresis. So in the recent years, there have been known that in the pathology of glaucoma also plays a role corneal hysteresis. So my question is about that. Do you measure in your patients, in your clinic, the corneal hysteresis in order to make a appropriate prognosis to the patients, and whether to do surgery or to do treatment?
So thank you for the fantastic question and the excellent lunch. And I would like to say that we would measure pachymetry for every patient. In my clinic we have an aura device, but I look for hysteresis mainly in normal pressure glaucoma cases. I'm not doing it for every single patient. I'm doing it when the diagnosis is a bit baffling, when you want to understand a little bit the situation of the patient. I mean, hysteresis is important for two reasons, obviously, as you know. One is the fact that thin corneas are associated with a higher potential for developing glaucoma. And second is that there are lots of theories about corneal hysteresis or a low degree of hysteresis associated with weakness in the cribriform plate of the optic nerve, which can be one of the explanations of why glaucoma develop more in patients with weaker corneas.
Thank you, Prof, for a great speech. I have a question about, you talked about the artificial intelligence, actually. I have a question about the app which can measure intraocular pressure at home. They create some device like a sensor wearable on the finger, and they can, how do you think, in your opinion, is that a good device to measure intraocular pressure even at home, or?
Well, it's a very, very clever question. Thank you for that. We've worked with multiple companies over many years about a home tonometer. And we participated in studies for the auto tonometer that was produced by iCare. But it's a mixed bag of worms, meaning in some cases, using a home tonometer is invaluable in the sense that you can discover things that will add a lot to how you can manage your cases. But in some cases, I found that they can make the patient mad. I mean, some patients would be all the time measuring their pressure. I had a patient of mine who bought a professional eye care, not the autotonometer, and his wife came and said, you know, I can't live like that. He wants me to measure his pressure 20 times per day. So again, when you go for something like that, I would suggest that you have to think clearly about if this will bring more good or more bad to the quality of life of patients. And everything comes back to the idea of quality of life in therapy, in medicine, and obviously in glaucoma. We are in the business of or improving quality of life, which, by the way, reminds me that when you have an early glaucoma patient who has a certain quality of life and you start putting him on medications, actually the big problem with glaucoma is not suffering from glaucoma, it's suffering from the eye drops. So initially, the quality of life is dropping because of us putting them on eye drops, not because they feel or see anything with their glaucoma. Thank you for the lovely question.
Thank you.
Thank you so much, Professor Shaarawy. 15 dəqiqəlik
Yes, come down.
15 dəqiqəlik fasiləyə çıxırıq, coffee break-ə çıxırıq.
Thank you once again for the beautiful invitation and for this very memorable night of mine. Now I've left you while you were sipping your coffee, staring at this idiotic photo that you have on the screen. And that is basically, as I was working on my presentation yesterday and found that PowerPoint has introduced an artificial intelligence module in PowerPoint where then they ask you, how can we help you, blah, blah, blah. So I said, draw me a photo of modern glaucoma surgery. So then they put you this thing where you don't know where the microscope is, the eyes look a little bit artificial, the surgery is done while doctors are not in scrubs and the doctor is showing his hair. So artificial intelligence for PowerPoint is not that intelligent, if you want to have my 2 cents. Now, glaucoma surgery. This is yours truly in 1994 when I did my first tube surgery. And I'll tell you why this photo is interesting. But 1994 is the first time I put an Ahmed valve, and you of course will observe that I have not changed at all from 1994. I mean, you better not have a different opinion. But at that time, the procedures that we were able to practice were basically subconjunctival filtration in the form of trabeculectomies, shunts, and non-penetrating glaucoma surgeries, and then cyclodestruction, ab externo, diode, or cryo. Those were the things that we could do. This was in 1994. In 2025, the choices are extremely different, as you can see. We have many procedures that are available that are either FDA or CE marked that we can use, and this, you would think that with all those new things that we're doing, we must be in a better place. I'm not sure that we are in a better place. Too many options means that, first of all, it puts a lot of responsibility on the glaucoma surgeon or on the ophthalmic surgeon when he or she are trying to choose what type of procedure they're going to do. It puts a lot of responsibility, and it means that we don't have one clear winner. We do not have one single ring to unite them all, to quote Lord of the Rings. But not to make things very difficult for you, if you look at all those devices or all those procedures, they all have similar things in common. We have not reinvented the wheel. We either do subconjunctival filtration in the form of creating blebs, or we do outflow pathway, conventional outflow pathway modulation, as you would do, for example, with a Cahook blade or an ab interno goniotomy. You can try to put a device or a tube in the suprachoroidal space. This started first with the CyPass, now extinct And there are two new models, the mini-ject and the third generation of eye stent that you can put in the suprachoroidal space. Or finally, you can destroy the ciliary body and close the tap with whatever device that you're using, diodes in the form of micro pulses, or something like ultrasound destruction of the ciliary body. Any of those four strategies can be addressed from inside the eye, ab internal, or from outside of the eye, ab external. But let's go to the original good operation that we had, trabeculectomy, and as I was talking to my expert friends in glaucoma, I'm always very proud that I was taught, trabeculectomy by nobody else than Peter Watson, the father of trabeculectomy. And interestingly, if you look at Kearns, who was the first big paper on trabeculectomy, came from Kearns, as you can see. And Kearns had the flap near to the fornix, not near to the limbus. So he was doing it in a different way. He was opening the flap towards him. Now we are opening the flap from the limbus, hinged on the limbus backwards. But Peter Watson told Kearns while they were sitting in a pub in Cambridge called the Spy Master. They were sitting together and Peter said, I think the flap should be in another place. And, Jean Kearns said, my flap works very well. So then they decided to do a randomized control trial, only to find that Peter Watson's flap is much better than John Kearns' flap, and since then we have been doing trabeculectomy in that way. But trabeculectomy, which was supposed to be a simple operation, ended up to be a really, really complicated procedure with no real guarantee for success and with a high potential for failure and for complications. So you have Penko from Moorfields who said, I will do the Moorfields safer surgery system for trabeculectomy. Sounds great, didn't change much. We had a slightly better looking blebs. But again, we were puncturing the eye, we were depending on specific flow that was very complicated. So comes in deep sclerectomy, which is very elegant because what you see here is we're removing the inner wall of Schlemm's canal with the juxtacaracal trabeculum without opening the eye. See, we are peeling that, nothing difficult, very easy step to do. The whole operation needs a learning curve, that's for sure. But once you do that, and by the way, we analyze this membrane over and over again, what you're peeling is the inner wall of Schlemm's canal and the juxtacaracal trabeculum, which means that you are removing the site of maximal obstruction in both primary and secondary open-angle glaucoma. So it makes sense. And one of the big fathers of ab external trabeculectomy, Tom Zimmerman, we were sitting in Basel many years ago, and he said, when we were doing trabeculectomy, I was thinking, when somebody has an appendix, we don't take the abdomen, we take the appendix. So when we are doing glaucoma, we should not drill a hole, we should take the tissue that creates an outflow, resistance. Makes perfect sense. This has been actually my go-to procedure for many years. The first book on non-penetrating surgery, I published it with my mentor, André Memo, in 1999. So I feel aged saying these numbers. Anyway, I was very young at that time, just for my credit. But any procedure that is filtering actually comes with the bleb. And glaucoma surgeons will usually ask their fellows to come and take a look at the bleb, because look at my bleb, it's better than any other person's bleb. It's it's functioning, it's raised, it's but actually most blebs will be atrophic, will be avascular, will be very bad news for the patient. Which reminds me, by the way, of a guy in Switzerland who was a poet writing poetry and was 85 years old, and he was the head of the theater of Geneva, and after doing an operation he came and said, I have a problem, I can hear my eyes. So initially I thought the guy went mad, but then he kept insisting, so I said, okay, let's take it further. So I actually invited a friend of mine who was a sound engineer who created a small studio around his eye to try to detect sound. And truly, after doing the studio, we could find a sound every time he blinked. So basically, there was like a pop sound every time he blinked, and the patient was going mad. So the easy thing was to actually rework the bleb, do a bleboplasty, and reduce the size. And then the sound went away. So I thought that everybody will live happily ever after, but the guy comes back later and says, I lost the sound and I'm very lonely. And that was, you know, I really have very little to advise to do. Maybe go get married at 85, I don't know, but I couldn't do better than that. So blebs are not a good thing, and there is a very big drive now in the glaucoma world for people to start using 0.5 milligram per milliliter for 3 whole minutes. That is equivalent of using a hydrogen bomb, not an atomic bomb, not a nuclear bomb. This is enormous. So please refrain from the 0.5 for 3 minutes, except really, if you think that the patient is extremely high risk. I use 0.28 milligram for 45 seconds. And I'm happy with that, I'm happy with my results. And even with the 0.28 milligram for 45 seconds, I still do at least 20 cases of bleboplasty in my city in Geneva, because I've been living in Geneva for more than 20 years. And I remember one of my very good friends, Mark Sherwood, says a glaucoma surgeon should be advised to leave his city every few years, because then he would not have to manage all the complications that will come with time. So then, you know, glaucoma surgeons, as simple-minded as we are, we thought that instead of trabeculectomies or instead of deep sclerectomies, let's put tubes. Tubes will make us all live happily, and it will work really well. And what else to rely on than the Hagen-Poiseuille equation? Hagen-Poiseuille equation looks at difference in pressure according to diameter of a liquid and diameter of the tube. It also will be depending on the viscosity and the length of the device. So with this equation, we should put something in the eye. One side the pressure will be like that, and the other side will be like this, which is absolutely rubbish. Simply because we're dealing with a living structure. And the eye, each eye has a different viscosity for the aqueous, different production of aqueous, and different degree of elimination. This would work. Hagen-Poiseuille law is very good if you are creating a sewage system for Baku, but not a drainage system for the eyes of your patients. Nevertheless, we have all those types of operations, and if we look at what we have now for tubes, I'm not going to speak a lot about pressure flow, but if you think about tubes, we have the Ahmed-Barveld clear path, the ADI, and now we have the iWatch, iPlate, and the pole implant. You can see the difference between a pressure flow and the Ahmed valve. The difference is humongous. It's really the pressure flow's big advantage is how small it is. We started doing the Ahmed valve in 1994, as I was mentioning, and have a special technique of putting an Ahmed valve that works very well in European patients and does not work as well in Middle Eastern patients. I do a big flap, which is 5 by 9, 5 in width and 9 in length, and then I do a deep dissection of sclera to be able to really bury the tube into the scleral wall. You thread it in, you take a few stitches there, and everything is done. This takes about 15 to 18 minutes, and you do not need any sort of foreign material. Works very well in Europeans. In Middle Easterns, I've done the technique in Emirates, in Saudi Arabia, in Egypt, in Morocco, in Algeria, and the rate of erosion is much higher. So for those cases, I would use sclera or pericardium. The ClearPath is a very nice device, but produced by New World Medical, the same company that actually does the Ahmed valve. The nice thing about it, it comes into two models, and what I really like about it is, first of all, you have the fixation points very anterior, so it's very easy to fix it. Second, it comes with the 4O ripcord already in the tube. And it comes as a whole set, so you have the needle to puncture, you have everything. And really it is a fast procedure. So you see here, we're putting it under the muscles. And you can, any glaucoma surgeon that has done Ahmed or Barbet will immediately understand how beautiful it is to have those two eyelids very anterior by which you can fix the tube without fiddling too much and trying to put the tube, fix the tube in a narrow area. So, fast fixation, and then, again, you are putting the tube through a 23G needle. I usually put any tube on a 24 or 25, depending on the tube, but they recommend that. And basically, you're putting the 4O under the conjunctiva, and everybody is happy. I know that you have the pole implant here, which is revolutionizing tube surgery because the internal lumen of the tube is 1.27 microns, and again, the external lumen is significantly smaller than the Ahmed or the Barbet. And if you compare a pole implant with a pressure flow, you see that they have exactly the same outer diameter. I've already shown you a photo of pressure flow versus Ahmed and Barbet, and here's pole versus pressure flow. So pole is significantly smaller in the outer diameter than both the Ahmed and the Barbet implant. Makes perfect sense because we do not want to put big stuff in the anterior chamber. By the way, if you look at the diameter of the Barbet and the Ahmed, they are bigger than the whole width of the angle in an open angle. So you're always touching the cornea, you're always touching the iris if you put it perfectly in the middle, which will result into endothelial cell loss with time. So, pole implant again, identify the tube, put a 6O proline inside the tube, it's quite flexible, and we thread it under the muscles, fix the implant, and again, the idea is relatively simple here. This is done in a child, actually, so we are taking a diagonal course for the tube in case we have to move it later on. And again, you have this, I hope you can see this very small square here, right there. It's a very small square box in the back where we actually can see the aqueous seeping out, and you can judge how much aqueous is leaving the eye, and we use a tutuplast to cover the tube. So our results with the pole implant has been really good, and we have published a study in the American Journal comparing pole to Ahmed in refractory congenital glaucoma cases to find that the results are almost identical, but you have the extra advantage of putting something smaller in the eye and having the ripcord that you can take away a year or two later if you have to. So you have a plan B. You don't really have a plan B with the Ahmed valve. Again, I just show you here, once again, you can increase or decrease the flow by moving the 6O proline inside or outside of the tube. So this is our study that was published in March 2025, so not yet, or coming in March 2025. And then we also experimented with the iWatch. This is a device that we worked, the Department of Ophthalmology in Geneva and Lausanne, as well as the EPFL in Lausanne. The EPFL is our polytechnic school, just like MIT in America, where we created this disc, as you can see. And this disc is magnetic, that you can move clockwise or anti-clockwise, and this will result into more pressure or less pressure on the tube. So basically, it's a tap, just like a tap that you have in your home. You can open it or close it, and thus you can reduce or increase the flow. Here you can see we have a special device to look at how much pressure is coming out through the dial. We are closed at 5 degrees, and then we want to open it to have more flow. So we decide on moving the disc, as you can see with the magnets. Those are devices that are actually, and once we open it, you can see the aqueous seeping much faster. I think it's quite obvious. Problem with this device is that it is expensive. It's really expensive to manufacture. So I love the device for putting it on a barbet or something like that, but it is an expensive device, and it adds expense to the actual cost of the operation in a world that is very challenged economically. And here is basically what we have. We have the Ahmed, we have the barbet, we have the barbet 250, we have the pole, and then we have the iPlate 200 and the iPlate 300. Those are the new ones that I want to mention now. And you can see the plate areas, and you can see which one has a valve or not, and you can see the tube diameters. So you can see here that the tube diameter, external diameter of the pole and the iPlate is similar, while the iPlate is a little bit bigger in the internal diameter compared to the pole. So this is the iPlate. It is actually a collaboration between our group in Swiss Vision and Rion Medical, which is a Swiss company. And it comes, as I said, in two sizes. And the nice thing is that you put it in, you put 5/0 in the tube. People who have done pole implant will tell you that it is challenging to put a 6/0 in pole. You have to spend some learning curve to be able to put it fast. The 5/0 is significantly easier to do. It's much faster, you know, a decent forceps, and it goes much faster than putting the 6/0 in pole. And the nice thing is that you do not have to put the iPlate under the muscles, so it saves time. Identifying the muscles and putting the plate under the muscles and taking time to make sure that it is really under the muscle takes time with the pole. With the new device, it is significantly faster to do, and it's easier to do because we're putting it between two muscles, as you can see here. I have to say that my results with the device so far has been exceptional. On the first post-operative lay, I have a pressure between 5 and 7 millimeters of mercury in the first 40 cases that I have done, which is very decent. By first month, I have an average pressure of 9. After 30 days, 9 is not too bad, with the ripcord still in. So we do not have a long-term follow-up. Our longest-term follow-up is 8 months. But so far, I have to say that I'm very excited about this device. And here you can see that, again, you can gauge very cleverly the amount of aqueous leaving the eye. If you will zoom in a little bit, let's do that. And if you look very closely here, you will see a drop coming in a path that we created. We created this groove to be able to see how fast the aqueous would be coming out. This specific patient, I thought the aqueous was going really nicely, but she was a 30 years old mother of a young child. She has a single eye. Her pressure was in the 40s. She is a -20 myope and post-vitrectomy and combined, you know, with phaco removal. This is a kind of a nightmare procedure. So for that case, I actually occluded with an 8/0 vicryl the tube, so that after 6 weeks, hopefully the pressure would have been better because of the resistance that will build under the flap. This is our new device. This is something I would say closer to a pressure flow, but much more sophisticated, because actually it has a valve, as you can see here. We just got a grant of $1 million from Alcon to develop the new device. We actually manufactured prototype. We started putting it in blind eyes under regulation from the Swiss authorities. And so far, again, we are quite happy with how this thing is working, because it's really regulating the pressure, and it is not associated with early hypotony. And we presume long term that it could do better than a pressure flow. compared to in terms of results and the need for needling post-operative, but this is something that is still being worked on. Now, a word of caution: whatever you are doing, putting something in the eye, remember that the patient doesn't only pay in dollars or Swiss francs, it also, or monat, it also patients will pay in endothelial cells. And endothelial cells, unlike money, is something that is not replaceable. So you cannot easily get other endothelial cells for this eye, except obviously if you graft the patient, which is something that I think we should not do if we can. And when you are placing a tube, please make sure that you put the tube deep into, even if you touch the iris, it's much better than having it near to the cornea, because if you put an Barbet or an Ahmed, the endothelial cell loss is about 7.5% per year if you are close to the cornea, which means the 7.5% is that you can easily calculate in a child how many years it will take before the cornea decompensates and you have to graft the cornea. So hit the iris if you like, please don't touch the cornea with your tubes. And we spoke about suppressing immediately. As soon as the pressure reaches 10 after a tube, I will give something to reduce the pressure. And I hope that everything that I spoke about now did not confuse you in terms of glaucoma surgery. So I'll give you my glaucoma cookbook, being an avid cook myself. For safety, I would still go for the Ahmed valve. For efficacy, a clear path would work very well for me. Long life, a pole or an eye plate. Eye syndrome, I go for a clear path. Never put an Ahmed in an eye syndrome. Neovascular glaucoma, we have excellent results with pole. In uveitic cases, don't put anything. If you can, don't open the eye. Deep sclerectomy or any sort of non-penetrating glaucoma surgery will do. But again, just to my last few slides, imagine that now we are living in a world where we have access, where every one of us will have access to all glaucoma data in the world. Everybody's pooling their data. Very soon, our studies will be not just big data, but big data with artificial intelligence that would allow us to have access to all glaucoma cases or all glaucoma data in the whole world. That nowadays, we will not just provide care based on certain risk factors like pachymetry, but we are also going to employ difficult and complex risk factors like genetics and using mega data to be able to provide real specific care and individualized care for our patients. Now, the thing that will change significantly also is that patients will be actively engaged much more in their choices. We as doctors, giving with the authority that we have, telling the patient, this is what you should do, is going to be a thing of the past. What is going to happen is we are going to have certain data that will be analyzed by artificial intelligence chatbots that will basically offer those options to patients with clear indications about every potential advantage and disadvantage for every therapy. And patients will start making choices themselves. So our role as ophthalmologists is definitely going to change in the coming 5 years. But we still will be able to offer true personalized care by screening the population genetically, by doing risk stratification, find the risk specifically for each patient, by providing personalized treatment for everybody, and by providing personalized lifestyle, as we said, in things like coffee and tea and things like that. So, is that really a disruptive technology? I would argue that yes, we are now in a phase of disruptive technology that is literally changing how we are going to be practicing glaucoma. And with that, I thank you very much for the invitation and thank you very much for your attention. It's my first time to Azerbaijan. I hope it will not be the last. Thank you very much.
Buyurun, suallarınızı verə bilərsiniz. Düşünürəm ki, çox maraqlı bir çıxış oldu. Zəhmət olmasa sualları. İlk əslində mənim sualım var idi. Dear Professor Tarek, I have one question about neovascular glaucoma because of retina and vitreous bridge. And neovascular glaucoma is bridge between retina and glaucoma. Who should treat the neovascular glaucoma? Glaucoma surgeon or retina surgeon?
The cause of neovascular glaucoma, as you all know, is ischemia of the retina. So I would say that that everything has to be done by the vitreoretinal surgeon to manage the ischemia. So initially, all types of PRP, injections, whatever you want to do, you need to basically try to control the ischemia. The point where the glaucoma surgeon has to intervene is if the angle is dead. If you have synechia more than 180 degrees. So whatever the retina surgeon will do at that position, it's not going to reduce the pressure. And that is the time when the glaucoma surgeon should jump and, in my experience, should put a tube. I'm not big on trabeculectomy for neovascular glaucomas. So it is really a situation where we have to address the retina in every possible way, but not to insist on continue. I have always this issue also with my retina surgeons in Geneva. They want to continue doing PRP even if the angle is completely closed. And then we have big quarrels that you are putting the patient in too much of pain because the pressure is very high and you continue to do PRPs while the pressure is 40 and there's no way once the angle is dead that it will open by itself. It doesn't happen. But at the same time, it doesn't make any sense that you get a patient with high pressure and you have not practiced photocoagulation or you did not inject or didn't do anything and you go for glaucoma surgery immediately. This is also not clever, especially because people, this is one of my favorite questions for the EBO or for multiple tests for our, or even for the Royal College. I'll make you cheat. I just put the exam for the Royal College of Ophthalmologists in London last week. One of the questions there is actually neovascular glaucoma is a secondary open angle glaucoma or is a secondary closed angle glaucoma? What do you think? Young people who are going to take tests or going to exams for EBO or for the fellowship in England. Secondary primary or secondary narrow angle glaucoma? Nobody wants to say? Or you all claim not to be going to take exams? I don't know. Question, because basically neovascular glaucoma is a secondary glaucoma that in the beginning is an open angle where you should not really go for surgery at that time, and then it becomes a closed angle when the zipping of the angle happens. So it can be open angle, it can be narrow angle. At the period which is when it's still open angle, I am not for jumping on the patient and doing glaucoma surgery. I will first make sure that I will treat the retina very well or get my vitreoretinal surgeon to manage it before we intervene as glaucoma surgeons. I hope this was, I'm sorry it's a very long answer, but it also reflects the pain that I've been suffering for decades.
What do you think about it, Dr. Jamil? Same question.
I agree with Dr. Tarek that the retina surgeon or glaucoma surgeon, it depends the stage of the neovascular glaucoma. It's very important because if the angle already closed or the membrane totally closed the angle, it doesn't matter how many you do laser surgery, laser procedure or the EV injection. So if stage first or second, yes, vitreoretinal surgeon can do EV or later PRP. That after this, the neovascularization decrease and intraocular can be go down.
Then I have a question for you. So in a bad neovascular glaucoma, and I'm actually asking to learn, do you start with a trabeculectomy or a tube?
No. Actually, if the patient came with a proliferative diabetic retinopathy, and I'll see the neovascularization, so I decided to do directly to shunt surgery.
Yes, I agree.
Yes.
I agree. We have the same opinion.
Thank you.
So it depends on the stage of the neovascularization. That's right. It's very important. You should do the colonoscopy to see, realize the condition of the eye, and then you will decide. So it's not important.
For me, first I'm doing injection, anti-VEGF, and after I'm doing or vitrectomy, or it's the case, of course, PRP. And after, if remain intraocular pressure, sent to glaucoma surgeon.
So I have a question for you, Septa, actually related to injections. For those cases, do you have a preferred molecule? So do you choose between one molecule over the other, or for the anti-VEGF? Do you have something that you specifically would be using for those kinds of difficult patients?
Sometimes you don't have any choose about patient, depend on patient. Mostly I'm doing Avastin, bevacizumab, and also Eylea. I'm doing Eylea.
Okay. And Vabysmo?
No.
Yes?
No.
No, because you don't have it, or because you don't like it?
We can order, but I'm not doing.
Okay. And one other question actually related to you as well. Why did they choose those very, very difficult names for anti-VEGF? I can't memorize the names. I remember the commercial names, but the scientific names are so difficult to pronounce. I mean, there's something wrong with those people.
Yes, really. I agree. Professor,
in my opinion, if neovascular glaucoma occur, then first of all need to do pan-retinal laser coagulation, then anti-VEGF.
Yes. I think I agree. I totally agree. But the retina big lady is there, so you should ask her.
I just wanted to ask, do you plant eye valves to children?
I never did eye valves. Yeah, you mean the small ones, the last?
One, yes.
The eye valves at this point of time, it's very, very recent technology. So the eye valves, we're using them on blind eyes and things like that. We haven't yet started putting them commercially because we need to make sure that they function very well. We got the CE mark, but the CE mark is very primitive and it's not, we're far from commercialization. I think it will take another 2 or 3 years. I mean, we have, working with new technology or designing new technology is like learning a new language. You need to put the time, you need to put the energy, but it's also something that stimulates your mind. And I'm always worried to be bored with what I'm doing. So I always need the intellectual stimulus to do something different. So we have a couple of projects in the tubes, and they're all, every one of them has advantages, disadvantages, some ideas behind them. But then you only know if they work when you really test them, and when you really test them on humans, not on animal models.
Another question regarding the ripcord. When you remove the ripcord after implantation pole?
Yeah, I don't remove them. That's a very, very important question. Now, do not remove the ripcord before 3 months. Never. And because you can end up with bad hypotenuse. So at least 3 months after, and only if the pressure is not controlled 3 months after, you have a pressure of like 19, 20 with or without medication, then you can consider removing the ripcord. But early is very bad. I had a patient coming from Libya, and he has a single eye, 6.4 and -20 again. So we put a pole implant, okay? And I have the bad habit of giving my patients my personal number. So he goes back to Libya and I'm bombarded with messages on WhatsApp and on my phone about pressure is high, we need to remove the thing. I mean, also because he understands what I did. So, you know, after a lot of headache, he comes back to Switzerland, and like 4 days before 3 months, I said, okay, let's remove it. We remove the ripcord, the pressure goes down to 3 with a loss of anti-chamber. So, then you take him again for the next day, and we had to occlude the tube, not this time with a ripcord. We actually took a stitch to close it. Then the pressure goes to 40. So, you know, again, it was a turbulent few weeks till the pressure stabilized at the end. But it was such a headache that I would never touch again a ripcord before at least 3 months, minimum 3 months.
It doesn't matter what type of the implant, bypass,
no, this works.
No,
this
only pole.
Only pole. Don't remove the ripcord before 3 months. Now, Barveld, you can remove the ripcord after 6 months or a couple of years. The eye plate is relatively new. We have only 8 months of follow-up, and we have not had to remove one single ripcord for the time being.
Any other question? Ümran Doktor. Zalda sual vermek isteyenler var. Where is it, Sona? Yes. Sona? Please.
Regarding the trabeculectomy, you showed us plastic plastics for the bad bleb, and if the tissue not enough, from where you catch it?
Yeah, that's an important question. So if the bleb is bad and you need to correct it, you need to be very imaginative because it changes from one situation to the other. First, when I do a bleboplasty, I never open all the way to the flap. I'm not very deep. I take always the surface layer or the surface layer with part of the tenon, but I do not expose the bleb, it's the flap itself, because you can end up with a hypotony. Now, the best scenario is for you to draw down the conjunctiva, which works in most of cases. But if you really have a very bad conjunctiva, or the conjunctiva is very thin because of that, you might do a rotational flap where you take part of the conjunctiva and move it from temporal or nasal towards the side of the flap. This is one way of doing it. And if that doesn't work, I usually take a piece of tenon and conjunctiva from the lower fornix and use it to cover the bleb. And make sure that when you do that, don't put mitomycin again, because then you will end up with a bad bleb once more. So that we just reviewed with my study coordinator data for about 32 bleboplasty that we've done in the last 4 years, and we lost pressure control in 2 out of the 32, one with hypotony and one with a pressure that was high. So basically it means that if you have only 2 out of 32 that have loss of pressure, then the procedure is relatively safe. And the most important indication, in my opinion, is not hypotony, is not a bleb leakage. I think the most important indication for bleboplasty is bleb dysesthesia, discomfort from the bleb that the patient feels. A patient would feel dry eyes, uncomfortable eyes, and you should not underestimate this. When the patient comes to you and says, I'm not happy, then he is or she is not happy, and this has to be taken with respect. It's like you have a patient on anti-glaucoma medications and he comes to you with red eyes, but the pressure is 10. It is not clever to say, stay on the medication despite the red eye because the pressure is good. This is bad economy, because the patient will not comply. Sooner or later he will stop, because who wants to live with red eyes? Second, if one day you need to go to surgery this red eye is inflamed, and the success rate of glaucoma procedures after many years of using anti-glaucoma medications is low. So this you should not do.
If the leg failure, will you do directly to shunt surgery, or you do second trabeculectomy?
I don't do second trabeculectomy, I don't do second deep sclerectomy. My second procedure after a failed filtering procedure is a tube.
And another question, if the first tube they fail, what you do? You put the second one in nasal part?
If the first tube fails, my second procedure will be partial cyclophotocoagulation on top of the tube. If that fails, I will do a second cyclophotocoagulation on top of the tube. If that fails, which happens rarely, touch wood, I would say that I would be cornered into putting another tube. And that will be usually an infranasal or well, if the problem is when you have the first tube, it's usually after you have destroyed some of the conjunctiva. So then your second tube is usually inferior, which is not fun. And then you also have to think intraoperatively if you want to remove the first tube. Because putting too many tubes in the antechamber is really not something something good. A very good friend of mine, got his rest his soul, Yohani Ayraksanen, was famous for what we call the Mercedes sign. It was called the Mercedes sign because he used to put 3 tubes. So the 3 tubes looked like a Mercedes sign. I would never, ever put a 3rd tube. But I've seen people, Yohani used to do that.
Another question. The pulse tubes is very thin and very difficult to manipulate when you insert into the anterior chamber. Then tube of the Ahmed or Beryl. What about do you put the Paul tubes pars plana?
I never tried doing them pars plana, to be honest. Theoretically, it could work in vitrectomized eyes, but I've never done that. What I do for the tube, for that pole, is the following. I would puncture with a 25G, and I will be holding the tip of the tube. First, I will make sure that the 6O is all the way to the tip, to give it a little bit of solidity. I will puncture, and at the same time I have the tube, the tip, held by a good time forceps. As I withdraw, I inject immediately. This means that you will not have a sudden loss of intraocular pressure. And by the way, the funny thing about the tube is that when you are puncturing with a 25, you make the puncture, then there's a little bit of blood comes out, and you don't see your hole. So the best way is you take an implant immediately. Otherwise, sometimes you don't see it. It's really very small, and it's not easy to see the 25G opening if you do not mark quite well where is the place.
So, bütün kimsizlerden sonra
2 questions.
Thank you, Professor, for your speech. At the last slide, you showed that in uveitic cases, you prefer to perform non-penetrating glaucoma surgery. But we usually use tubes, shunts in these cases. I would like to ask, do you perform implants for uveitic cases, and which non-penetrating surgery do you do?
Yeah, I do a deep sclerectomy for those cases, especially if the angle is completely devoid of synechia, that superior angle. Now imagine that you have a case where the superior angle is closed by synechia, then I will go for a plate, for a tube. Non-penetrating surgery for deep sclerectomy for uveitic cases is perfect because you do not open the eye, so do not entice inflammation. But I have no problem with putting a tube if the angle is closed. So first operation is that, or it might be a tube if there's a synechia in the superior angle. If the angle is open, then deep sclerectomy. If it doesn't work, then a tube.
Thank you. Dear Professor Shaarawy, it's a great honor to host you in Baku. My question is about MIGS. I wonder about your opinion about MIGS procedures, because nowadays we detect glaucoma in early stages.
Yeah.
What do you think about it?
Okay, I worked a lot on MIGS surgery, and almost all the new devices under MIGS is something that I worked in initial phases. So we published on the Zen, we published on the Miniject, on the pressor flow, on the trabectome, on the CyPass. I think MIGS have a good place in our practice, mainly in combined procedures. So phaco plus a MIGS procedure. Actually, my preferred combined procedure will be phaco with a Cahook dual blade, because it's cheap, it's easy to do, I don't leave something in the antechamber. So MIGS has a place, and they are useful. Having said so, if you look at the United States of America and the number of procedures that are being done, you'll find that 78% of glaucoma procedures are MIGS, and the rest are tubes and trabeculectomies. This is not evidence-based. This is mainly driven by the fact that phaco surgeons find it very easy to do a phaco and then inject a CyPass, but not CyPass, iStent. iStent is perfect for a phaco surgeon. You inject it at the end of a procedure. There's no pre-operative or post-operative follow-up, and you make a lot of money. So it is really, this surge in MIGS is overemphasized because of reimbursement. I tell you, if the reimbursement of something like the iStent becomes as low as $10, nobody will use it at all in the United States of America. So we have to be very cautious about what we use, and we have to be convinced of using it for good reasons. I have nothing against MIGS, but I think we have to be very careful about what we do. And I think it's very important that when we decide on MIGS procedures, is not to do it because the other guy in the other hospital is doing it. This is the worst. It's peer pressure. Because the other guy is doing it, then I have to do it. That doesn't make any sense to me. You have to be convinced, and then you have to put the effort in one or two. But if you disperse your experience on 15 different MIGS, there's no way that you will be proficient in the ones that you believe in. So, nothing against MIGS, but it depends all on where and when to use.
Yeah.
Another Lala. Dear, my best girl.
So Nada, before you ask your question, I take it that your temperature has stabilized. I hope you are not here and you're tired. I hope you got better.
Yeah, I'm
Good,
fine. Thanks
good,
for asking.
good.
I'm asking about, as a young VR, I want to know which tube would you prefer in the vitrectomized eyes? It depends, or do you have an idea?
It's a tough question because we don't have a study to answer that. You're asking me about my personal preference, and my personal preference, unfortunately, will have to fall between something like Poland eye plate from one side because of efficacy, or Ahmed valve because of safety. Your worst nightmares as a glaucoma surgeon will happen in a vitrectomized eye because the vitreous is not there and there's nothing to support your retina. Suprachoroidal hemorrhages, when they happen, you're scarred for life. So if I'm absolutely scared, I would put an Ahmed valve. If I feel a little bit courageous, I would put an eye plate or port. So it really depends on the patient. This last case that I was showing you was a vitrectomized eye, and I put an eye plate. And I traveled 48 hours after coming to Baku. So when I go back, I hope that you will still be doing well.
Thank you, Prof.
Başqa sualı olan yoxdursa, Cəmil doktorun bir dənə elanı var. Okay, hələ sualı var Cəmil doktorun. He has question, one more.
Regarding again with court. You remove the record on the slit lamp in the office or in OT? First question, and where you leave the end of the suture, in the inferior or superior part of the?
I put it usually temporal. I put it temporal. I tried superior, but then I moved to temporal. I remove it under the slit lamp in the examination office, with one exception: if I can't see it. Sometimes you have a lot of fibrosis on top of it, so you can't see it. Then I would take them into the operating theater and fit it and try to find it. Also, the other exception is obviously children. Putting a whole implant in a child, and then 4 months later, just I think 3 days ago, I had to take a child to the operating theater, and I forgot where I put it. I did not put my notes where I put it. So what you do is you take something like a spatula and you compress the conjunctiva superiorly, inferiorly, temporally, everywhere to try to find it. And I usually have one of my assistants with me because I need extra eyes. Because sometimes I will miss it, and then you find your resident and says, here's the blue thing. But then after doing that, I try to make a very small scratch with an insulin needle. And the trick is it has to be deep, because if you open the conjunctiva and you open the tenon and you try to take it out, it won't work. And then also the other tip is that when you open the conjunctiva and tenon, you have to make sure that you don't hurt, you don't touch a vessel. Because if you touch the vessel, God be with you, you will be spending 30 minutes trying to stop the bleeding, and you know, the scrub nurse will not be sufficient to, you know, throw water. You need buckets of water really to be able, and the diathermy in that. And maybe the last thing is that I don't close the opening in the conjunctiva until once I get it out, I leave it open, it usually closes by itself immediately. I don't need to take stitches.
Any other question? Renee, please.
Dear Professor, I would like to ask you about a question about juvenile glaucoma. So I would like to know from your practice how you are managing these patients. In my case, there was a boy with 14 millimeter hydrargyrum, the IOP, and he came to our clinic. He wants that I will do for him an excimer laser surgery, but during the observation, I watched that there was an OCT, and there was a change in OCT and also in peripheric perimetry. And so, what should you do in this case?
But the pressure is high.
The pressure is normal.
The pressure is
14, yeah. And the age is 18.
Yeah. Pressure is normal. Is he a high myope?
Not high myopia. -3 myopia, and the corneal thickness is 550.
And how old is he?
18.
How old?
18.
18. Okay. First of all, there are no OCTs in the market that have a normative database for 18-year-olds. So don't rely on the OCT. That would be the first thing. Visual field, I will rely on the visual field only on the third time, not on the first and not on the second. You know, those are young people, and whatever you're going to do can affect them significantly, so you have to tread very cautiously. And if you can get away without treatment, without surgery, I would try to do that if I can. So first rule is to make 100% sure that the patient is really glaucomatous. I, after 30-something years in glaucoma, have never seen a young patient with normal pressure glaucoma. I've never seen that. And it is not reported in Japan, where 80% of cases are normal pressure glaucoma. So I would very much doubt the diagnosis of glaucoma before. I need a lot of evidence. And if the evidence is there in a case like that where I'm not solid about the diagnosis, I would start with medications maybe and wait, and will go to surgery only if my hand is tied. These are very different from a case of post-LASIK open-angle glaucoma. I see a lot of those cases. You know, I get a lot of patients from Lebanon who had LASIKs and they come back 2 or 3 years later with severe glaucoma pressure in the 60s. You go immediately for a deep sclerectomy in those cases because you do not want to do a trabeculectomy, because if you do a trabeculectomy in those cases, you end up with losing the lens, which becomes cataractus, and when you do the phaco to remove the lens, patient will lose accommodation, and the 30% the trabeculectomy will be closed. So it's a spiral, it's a vicious circle. So in these cases, I will jump into surgery, I will do deep sclerectomy because I will not harm the lens, and I will do it fast. But what you are describing is very tricky. So I will be very, very prudent and very cautious. I will not run into glaucoma surgery in a case like that. And best of luck. Do you have when you call a lady in Azerbaijan, do you usually use, or a man, the name of their sons or daughters? Because for example, my son is called Hussein, and among my friends I will be called Abu Hussein, the father of Hussein. You don't have this tradition. Mother of Yusuf.
No.
Okay.
Thank you. Thank you so much, dear Tarek, Professor Tarek. Your very beautiful, wonderful presentation. Thank you so much.
Thank you. Thank you very much for having me.
İcazənizlə demək istəyirəm, əslində çox həyəcanlıyam. Çox təşəkkürümü bildirirəm hamınıza, dəyərli kollegalar. Həqiqətən çox dəyərlisiniz mənim üçün. Dəyərli müəllimlərim, hamınıza bir daha təşəkkürümü bildirirəm. İlk növbədə Professor Dr. Shaarawyyə uzaqdan gəlib belə gözəl prezentasiyanı bizə təqdim elədiyi üçün ona minnətdarlığımı bildirirəm. Və ilk növbədə Caspian AIS şirkətindən, başda Vaysif müəllim olmaqla, çox sağ olun Vaysif müəllim. Vəsilə xanım bütün bu konferansın ağırlığını maddi və mənəvi tərəfdən qarşıladığı, dəstəklədiyi üçün Caspian AIS şirkətinə bir daha minnətdarlıq bildirirəm. Minnətdarlığımı bildirmək istəyirəm dəyərli moderatorlara, çox dəyərli qısıt vaxtlarından istifadə edərək İmran Cərulazadəyə, çox sağ olun İmran doktor, Cəmil Həsənova, bütün fikirləri bir yerdə bölüşdüyümüz, hər bir şey detalına qədər ilk gündən Dr. Cəmillə planlı olaraq ona da minnətdarlığımı bildirmək istəyirəm. Nigar xanım, Mahmudova Həsənovaya təşəkkürümü bildirirəm. Rəfadar doktor üzürlü səbəbdən evə getməli, qaçmalı oldu. Rəfadar doktora təşəkkürümü bildirirəm. Təşəkkürümü bildirmək istəyirəm mənim gözəl qızım Lalə Məmmədovaya. O da ilk gündən bütün sosial şəbəkələrdə, bütün günü mənlə bir yerdə çox sağ olsun və hamınıza bir daha təşəkkürümü bildirirəm. Və çox xahiş edərdim ki, son olaraq axşam yeməyinə hamınızı dəvət edirəm. Əlbəttə, Dr. Shaarawy, she has one question.
Siz tərcümə edəcəksiniz da, qövsvari daralmalarda, daralmasında işiniz neuropatiya ilə glaucoma necə diferensiyasiya edəcək?
When you have general setomas, isn't it? And how do you differentiate with ischemic neuropathy on visual field?
So, as I said, we do not diagnose glaucoma with only one investigation. We have the sum of things that you can see together, and the hallmark of anything that is glaucomatous is excavation. So optic neuropathy does not happen with excavation. We do not speak of glaucoma, we speak of the glaucomas, because what joins all glaucomas together is the fact that the glaucomatous optic neuropathy has a characteristic pathognomonic sign, which is excavation. You do not, does that work? You do not? So, atrophy and pallor is something that you see with other types of optic neuropathy. But glaucoma, you only call it glaucoma when there is inflammation.
Nuş olsun.
Sağlayış gibi yoksa. Hayır, o da ona bir